So we are scanning on the Apleo i800 Canon system. Our lovely patient is 20 weeks, 21 weeks. Don't take any weeks away from pregnant women. Okay, and we're gonna go, I'm gonna just show you how I start looking at the pregnancy. So we're scanning with a transducer that is I8C times 1. It's a trans-abdominal probe. So I'm gonna start by seeing the presentation. So I'm angling towards the pelvis. Here's the baby's face here, the eyes. So the baby in a cephalic presentation, and I'm sliding up. So given the position, a longitudinal lie of the baby in the uterus. So I'm going all the way into the bladder. Do you know what you're having? Or? Okay. I don't want to spoil it for the world. That would be a special reveal here. So I'll go all the way to the top to make sure the baby. So the baby is in a longitudinal presentation. So the left side of the fetus would be down. So let me pull an arrow on the screen. Here you go. So the stomach is on the left side. The apex of the heart is on the left side. And I'm going to look at the descending aorta is also on the left side. Remember, I'm going to come from the side of the abdomen to make sure I have one full rib on each side. That tells me I'm in a perfect transverse plane. And then I'm going to go into the abdomen. So here's the stomach, descending aorta, IVC on the right side. Then I'm going to look at the umbilical vein coming in, and I want to make sure that the umbilical vein, the portal sinus, turns towards the right side. That tells me that there is no persistent right umbilical vein, and then we will talk about that tomorrow when we talk about the venous system. So I am in the cardiac, no, I'm in the OB package. Okay, so let me reduce the velocity of the color so I can stay in the abdomen a little bit, and I'm gonna look at the curvature of the portal sinus here, and I see the gallbladder here. Again, with color Doppler, you see no blood flow in the gallbladder, and that tells me that there's a normal curvature of the portal sinus. Tomorrow, I'll show you the anatomy of the venous system in the stomach and how you can diagnose abnormalities related to that. So here you see the 3 hepatic veins, right, middle, and left, coming into the IVC, and that's a subdiaphragmatic plane. Right below they enter the right atrium, as you see right here, and then below that is the portal sinus system. So I'm going to go back to one full rib on each side. Here you have the umbilical vein coming in. You have the left portal system here. So the umbilical vein and the portal sinus are actually part of the left portal system. There are 3 veins that come out here, and then you have the right portal system on this side here. The ductus venosus is right here. You see is an offshoot at the level of the portal sinus, as you see right here. And you could always see aliasing in the ductus venosus because of the narrowness of it and the accelerated blood that goes through it. So normal abdominal circumference anatomy, normal fetal situs. See the renal arteries here coming to each side. So I'm gonna now slide, I'm gonna get out of color. I'm gonna go into my heart setting. Okay, and now you see the heart setting, how automatically optimizes for you. So what I'm gonna do first is I'm gonna reduce the depth. Remember, you scan with minimum depth. Make sure your focal zone is always at the level where you want it. And now once I get there, I'm going to reduce the sector width. Let me see, how do I do that?
Yep, that one, and just roll
and then, okay, let me get rid of the arrow.
That one, and just roll it.
Okay. Sorry, my hands are pressing all different instruments. Yeah.
You're fine.
Okay.
This one?
Yeah.
And then just the
Yeah.
trackball.
So we're going to reduce the sector width because that increases your frame rate. And now that I am where I need to be, again, I'm going to turn around to make sure I have a full rib on top and bottom. Always remove the pressure that you have on the abdomen. And now I'm going to angle towards the fetal heart. Now you see I'm obstructed here by the extremity here and by the angle of insonation. So I'm going to try to image from this area here. So I'm going to slide on the abdomen away, and you see how much clearer I see the heart here by avoiding this extremity that was shadowing down and avoiding coming into intercostal spaces into the heart. So I always want to make sure that the image is in the center of your ultrasound screen. So see how I was here, and I, on purpose, slided my transducer along its longitudinal axis to put the image in the center of the screen at the level of the focal zone. I probably can do one more depth reduction here. And so I'm happy with where the heart is. Then I can go and do some magnification. So once I've adjusted all these, then I can magnify the heart. I'm going to reduce a little bit the 2D gain, and I'm happy with this 4-chamber view here. So anatomically, I have the left atrium here, the right atrium, right ventricle moderator band, left ventricle walls are smooth. Then I'm looking at the septum to make sure that the contractility of the right and left ventricle are equal, and the septum stays in the middle. The septum does not really move. When the septum flails back and forth, usually associated with significant problems in the contractility of the heart. Leaflet of the foramen ovale is opening into the left atrium as it should. I see a very nice foramen ovale here, and this is the area we talked about with the atrioventricular septal defect. So that's the atrial septum primum, and that's the ventricular septum here. These two areas appear really intact. So now that I've established at least the size of the ventricles and the contractility, now I'm going to slide a little bit coming from the abdomen because I'm going to angle up to get the LVOT. So I'm angling up to get the LVOT. Here's the ascending aorta right here. So I assume this is the aorta. I don't really know yet whether this is the aorta or this is the pulmonary. So I'm going to call this the LVOT. There's a bit of an echo dropout here that shows that there's a perimembranous VSD, but that's not the case. So I'm going to turn a little bit. You see I'm coming perpendicular to this to see the angle that the ascending aorta makes with the ventricular septum. And I'll talk about this tomorrow. That is really important. In overriding aorta, you tend to lose that angle that the ascending aorta makes with the ventricular septum. I'm looking at the valve, and I see that the valve disappears during systole, another important feature looking for stenosis. And I'm looking at the size of the aorta post-valvular. I'm making sure that the aorta is smooth and is equal in size as it goes out. There's no dilation beyond the valve, which can suggest the presence of aortic stenosis. So from here, remember, descending aorta is on the left side. So the aorta actually makes this curve here and then makes an acute curve in the upper chest to come down on the left side. From here, I can angle down meaning towards the baby's head, so up in this situation, to get the pulmonary artery or the other vessel coming out. Now, how do I know this is the pulmonary artery? I'm going to try to come a little bit from the abdomen and see if I can document the division of that vessel. So what we call the 3-vessel view. And here you see this right pulmonary artery coming out of this vessel. So to me, I've determined this is the pulmonary artery then. And here's the classic 3-vessel view. See how thin that view is? So you go actually from the 3-vessel view, which shows the right and left here. You can't see the left very well in the orientation that I'm at. If I slide a little bit more in the mediastinum, I get what's called the ductal arch view, which you see the pulmonary artery, longitudinal of the ductal arch, cross-section of the aorta, come back, baby, and cross-section of the supravena cava, okay? If I keep sliding up, then I get the classic 3-vessel trachea view. So again, really important views for you to practice. You go from the LVOT and the RVOT. The first plane is the 3-vessel view out of that. Very, very slight plane and actually difficult to get depending on the position of the baby. And then after that, you get the ductal arch view, referred in the fetal echo guidelines as the 3-vessel view with the ductal arch. I lost that battle, but That's the nomenclature that is used now. And then from there, if you keep angling a little bit of tilt towards the left side, you get the three-vessel trachea view. Here you see the trachea, supravena cava, aorta, aortic isthmus, pulmonary artery, ductal arch. If you keep sliding up in the chest, you get what is called the aortic isthmus view. And I'm going to freeze here to show you this important view here. So in this view, you actually have only the aortic arch. You're above all the pulmonary circulation. You have the top of the aortic arch, and you see, don't mistake this with an abnormal three-vessel trachea view, because this arises in the middle of the chest, in the middle of the upper chest. So that is the classic aortic arch view. You see supravena cava, aorta, and the trachea right here. And if you keep sliding up from this view, you get the brachiocephalic vein. So I'm going to turn a little bit to highlight the brachiocephalic vein, and this is your brachiocephalic vein here at the border of the thymus gland. Now I'm going to show you color of all these applications. So we're going to keep this in the middle. So here's the 4-chamber view. I'm going to put now color on the 5-chamber view. So I'm going to use this called ADF feature on this system. Now look how wide my color box is. And your frame rate typically is significantly impacted. It's 22 frames per second. So I'm going to go in and reduce this to the minimum that I need. And now I am about 43 frames per second. And you see that right here. So that is how you make sure that you always scan the fetal heart with the maximum frame rates that you can to ensure visibility. So I'm going to increase the scale of this. So let me see where it is. So I'm at 25 now, so I press it down, or?
I roll up.
Okay, it's not moving, so.
Let me see. We can turn this one.
Okay, great. So I'm up to about 32 centimeters per second. Let me go back to remember the ribs, so I'm going to go back to one full rib on either side, and I'm going to go to the 4-chamber view here with color, and you can see the LVOT is coming up a little bit here. Now I'm going to go into the views we talked about. So I'm going to come from the abdomen and angle down. So here you see on color Doppler, if I cine loop back, you see the pulmonary artery and its division. So here's the pulmonary artery. This is the right, and this is the left pulmonary artery. Right and left. So that's the classic three-vessel view. So I'm going to go back to that now that you've seen it. I'm going to come in a little bit from the abdomen to get that. Here's the division. Now I slide a little bit more up, and this is your classic ductal arch view. Here you have longitudinal of the pulmonary artery and the ductal arch, cross-section of the aorta, and then you see the azygous vein here dumping into the supravena cava. Keep sliding up, angle towards the left side, and you have the classic three-vessel trachea view here. Okay, and that is really an important view that Michelle is going to talk about tomorrow. Now, keep sliding up, you get the aortic arch view. You only see the aortic arch view, supravena cava. I don't see filling inside supravena cava because I'm in a high velocity. Now, to see the pulmonary veins, I'm going to drop down my velocity scale. I'm going to turn a little bit parallel to it, and here's your pulmonary veins right here. I'm talking about the brachiocephalic vein, and here's your brachiocephalic vein here dumping into the supravena cava. Brachiocephalic vein and a portion of the aortic isthmus right here. And this is the thymus gland right behind the brachiocephalic vein. Typically runs at the outer border, sometimes intrathymic in less than 1% of cases. Here's are the mammarian arteries that you see them on each side that actually borders the thymus gland. There's a good markers of where the thymus gland should be. The brachiocephalic vein, we'll talk about it tomorrow, is really important, especially when you have persistent left supravena cavas, total anomalous venous return of the supracardiac type, and so forth. So that's the anatomy showing from the bottom up. Now, if I want to see the pulmonary veins, I'm in a good orientation here. So I'm gonna remember, see my ribs on top. So I'm gonna make sure I am in a perfect, here's the three hepatic veins draining into the prevena cava. So I'm subdiaphragmatic here. So let's go to the 4-chamber view. And you see here 2 pulmonary veins coming in. So what you see here is you have a pulmonary artery and a pulmonary vein that are hugging each other's here. So that's the pulmonary vein coming in. This is the right inferior pulmonary veins. That's a branch pulmonary artery going out. And you see here the left inferior pulmonary vein coming to dump into the left atrium. So, and here's the anatomy right here. And you can see the other pulmonary vein coming in. So now with the newer technologies that exist on the systems, you can see both upper and lower pulmonary, superior and inferior pulmonary veins in one view, as you see right here. Look at this superior pulmonary vein coming in, inferior right, superior right, left, and left. It is important to get into the habit of measuring the spectral Doppler of the pulmonary veins and to see the normal spectral Doppler pattern of the pulmonary veins, because that could help you in confirming the pulmonary veins, 1, and 2, in ensuring that in cases where you're suspicious, I don't see them well, maybe there is a collector vein behind. In many of those anomalous venous return, there is obstruction to flow, and the pulmonary veins will show an abnormal pattern. And I think we have a lecture tomorrow on that. So I'm going to go back to 2D, and now I'm out of the heart here. Now I'm in this position here, so let me try to get a sagittal view. So now this is a nicer view to look at the aorta also, that I like in cases where you have difficulty scanning. So I'm going to enlarge this section right here and showing you. So what you see here is you see the inferior ventricle that looks like the left ventricle, and you see the aorta coming out, you see the aortic valve, and under here you see the branch right pulmonary artery coursing under the aortic arch. And that's a very nice view. Now if I angle a little bit to the right side of the fetus, then I see the pulmonary artery coming out. So you got pulmonary artery coming out in this direction towards the fetal left shoulder, and the aorta is coming out towards the fetal right shoulder. And you see the perpendicular pattern of these 2 great arteries as they come out. So from here, if I keep turning around, I start to get the aortic arch here. Again, the aorta coming out and turning around, and you confirm that by seeing head and neck vessels coming out. Now, if I need to I want to get in a way, I'm going to go back and give myself a bit more depth. I want to get in a sagittal view of the spine. See how I'm coming all the way from the side of the abdomen. Sagittal view of the spine. There are 3 important planes here. Here's your ductal arch, beginning of your ductal arch. So you see, let me enlarge here so you can see. Oops, sorry. So cross-section of the ventricles, like we talked about and showed before. You move to the right parasagittal plane, you will see the pulmonary artery coming out, right pulmonary artery coming here, and then connecting with the descending aorta. If I go more towards the left side, I see the aortic arch coming out, connecting down with the descending aortic arch and head and neck vessels. Here you have the right atrium. Look at the right atrial appendage. This is a great view when you are dealing with heterotaxy and trying to determine which atria is which. This is really an important view because you see this is the right atrium and you see the IVC coming in, and here's the Eustachian valve at the border of as the IVC enters the right atrium. You see that clearly. And then in this view, you see the SVC coming from on top, the IVC. So I am right parasagittal here. And here's branch pulmonary artery under. I'm right parasagittal here. Then I go a little bit more sagittal. I get the aortic arch because I'm angling from right to left, and then if I go more towards the right side, then I get the pulmonary artery coming out. Important planes to look into. Not really helpful in the first trimester. In the first trimester, what we look at, and I'll show you on Saturday, we just get a 4-chamber view with color Doppler and a 3-vessel trachea view as part of cardiac screening in the first trimester. Now look where I am now. The baby turned. So the reason I'm struggling to get a perfect 4-chamber view is look at my ribs on either side. So what I need to do here, I need to go to the abdomen and angle down. And as I go in to remove the pressure on the abdomen, and you see how I ended up with 1 full rib on either side, and now I have a perfect 4-chamber view. Clearly, really important, look at the periphery first, and then come back into what you need to look into. And from this orientation, again, this is easy to get the planes that you need to get moving forward. So what I would suggest to take home with you from this is learn to get the planes from the 4-chamber view all the way to the brachiocephalic vein. So starting from the 4-chamber view, 5-chamber view, the right ventricular outflow with the 3-vessel view, then the ductal arch view, then the 3-vessel trachea view, then the aortic isthmus view, then the brachiocephalic. I can't see the brachiocephalic in this orientation. I need to come from the side and angle back up to see the brachiocephalic. And if you're using color Doppler, remember you're losing veins, so your velocity should be reduced, your gain should be increased to be able to see that. What else I can show you? So this system is also really good to look at the placental flow, and that's what we used looking at our NIH study on the human placenta. So I'm going to reduce the depth here to really highlight the placenta. I'm going to move the focal zone up to the level of where the placenta is. That's my interest. Increase the 2D gain a little bit. And now I'm going to go into something called SMI, which stands for Superb Microvascular Imaging. And in this SMI, you can actually see spiral arteries coming down. And you can see, let me enlarge this a little bit.
This one.
And you see the fetal placental arterioles coming from here. You see them right here. And then you see the spiral arteries. At 21 weeks, you could see that the spiral artery is not pulsating that well because it has gone through the maternal adaptation. So if I look at the spectral Doppler of this vessel right here, you're going to see a maternal pulse. So let me just open the velocity. And typically by 22 to 24 weeks, they will have the same almost features as venous flow if they've gone through the full adaptation. And that's really helpful to assess the spiral arterial flow and the fetal placental arterioles and how they change in pregnancy. And we've been doing this for 6 years, so we have a huge amount of data related to placental adaptation and markers of placental disease and so forth. Okay, any questions from the audience? Okay, so I think between this morning and this presentation, you should have a very good concept of fetal cardiac anatomy. Thank you, Karen.
Thank you very much.
And thank you for your beautiful baby.